Welcome to Grassroots Health, next production of its webinar series, Scientists Answer Your Questions. I'm Carol Baggerly, Director of Grassroots Health, and today it is my very great pleasure to present to you Dr. Robert Heaney, Professor of Medicine at Creighton University, and very joyfully I'm happy to say he also is our Research Director. Today's topic is why test vitamin D. There is a lot of question out there about that. And one of the things that you can note over on the right side in that little green box there, the very last sentence, therapeutic adequacy of vitamin D depends not on dose, but on achieved serum level, which can only be ascertained by measurement. Dr. Heaney, it's all yours.
Thank you, Carol. We're going to talk really about 2 points: why it's important to measure vitamin D status and why a certain status is important in its own right. And so let's start with why it's important to measure. What I'm showing in this slide is a set of over 3,700 individual values of serum 25-hydroxy vitamin D. That's the way we assess vitamin D status. And the plot shows that we have vitamin D intake on the horizontal axis measured in thousands of international units per day. And on the vertical axis, we have the serum 25-hydroxy vitamin D level in the units that are typically used in the United States. And you can see that the higher your intake, the more likely your serum 25-hydroxy D is going to rise or be higher. But you also see that there's a tremendous lot of spread around the data. And I'm going to focus here for a moment on just one intake point there. That's at 5,000 international units per day. Let's take all those points and spread them out horizontally and do what's called a frequency distribution. And what that does is to show you how many people were at one particular point of that distribution and how many were at others. But as you can see immediately, we have values ranging from a low of 20 on the left to a high of over 140 on the right. And all these people were getting exactly the same dose. Now, how would you know how much of a rise a particular person would have gotten with that dose? Well, there's only one way you can tell, and that's by measuring it. Here's another study which we performed recently, in which we gave a large dose to a group of individuals. At one time, we sat them down in front of us, they all swallowed this dose, and then we measured their blood level for 4 months. We gave them a big enough dose that we could see something throughout that entire period of time. And what you see plotted here is the rise to what's called Cmax, that is the maximum concentration that each individual achieved at some point in time after taking the dose of vitamin D by mouth. The average is shown by the red bar, but you see, once again, they all got it. They all got it at one time. They all got it sitting in front of us. We know they got it. But the lowest rise was about 11 nanomoles per liter, which in terms of nanograms per milliliter would be a little bit less than 5, which is not much. And the highest was close to 80. Now, you might expect some of that variation to be due to differences in body size. And indeed, if you adjust for weight, the spread diminishes a little, but there's still a tremendous spread. You can see that there, from just below 20 nanomoles per liter to above 65 nanomoles per liter. That's at least a threefold spread, maybe closer to fourfold spread. There's no way we could have guessed where those people would be. We can guess where the average is going to be because we've got plenty of experience with that. But the individuals can be all over the map. And so the bottom line is we simply have to measure it. Now, the second point that we want to make is why vitamin D is important. That is, why would you want to know? Well, first of all, I think we all understand from grade school nutrition that vitamin D is necessary to help the body absorb enough calcium from our diets. We take that pretty much for granted. But vitamin D also functions as a part of the chemical apparatus that enables all of our body systems to respond to routine, ordinary, everyday signals and stresses. How do we react? How do we compensate? When vitamin D status is not adequate, then none of our body systems will work at peak efficiency. So it's not just one thing. It's not just bone. It's not just calcium. It's all of the body systems. They all need vitamin D, and they all need enough of it in order to respond at peak efficiency. Now, what are the consequences when they don't? Well, this is a partial list of many of the disorders or dysfunctions that have accumulated a large evidence base. For instance, the obvious one are bone diseases, falls and fractures. We've known about those for years. High blood pressure, increased risk of cardiac disease and death, increased risk of complications of pregnancy, such as low birth weight, prematurity, increased numbers of cesarean sections, and so forth. Diabetes and metabolic syndrome all are influenced by vitamin D status, as is gum disease in the mouth, decreased resistance to infection, such as the flu or tuberculosis, various cancers, increased risk of multiple sclerosis, increased risk of mental disorders, such as schizophrenia. And at this point, I'm going to turn the microphone over to Carol, who's going to regale you with some of the data from some of these disorders that I've just kind of listed very hurriedly. Carol?
Thank you. I'm going to talk about why 25-OSD level is important, and in particular, which levels, and to differentiate somewhat between levels and different diseases. The first slide I want to show you here is actually exactly the same one that Dr. Heaney showed you earlier, but with a new line on it. That line across the horizontal thing there that says 40 nanograms per milliliter is where people are at that level. And what I want to bring your attention to right now, for the purposes of looking at the rest of my slides, is look at all of the points that are below 40 nanograms per milliliter. They're bunched over at the pretty much around less than the 10,000 IU per day. But all of those people have less than 40 nanograms per milliliter. And some of them are taking rather substantial doses. So what difference does it make? Another study that Dr. Heaney himself was a major participant in at Creighton University was one that was done on vitamin D and cancer. And what you see here on this chart is over a 4-year period where they gave nothing to this placebo group down here. You can see that they had a lower cancer-free, and up at the top, the calcium plus D had a bigger effect. There was actually a 77% reduction in the incidence of all cancers as a result of getting vitamin D over that 4-year period. Indeed, all of those cancers, look at that very bottom line there, the total percentage. There was an only 2% occurrence of cancer in the treatment group versus 6.8%. And each and every cancer that you pick, there was more of it in the group that had no vitamin D. So vitamin D matters to cancer. But what else do we know from that study? What we know from that study, back again to the serum level, is that group of people all started out with an average serum level of 28 nanograms per milliliter. The average at the end of the study, and they were taking 1,100 IU of vitamin D a day, which is not a lot, the average at the end was 38. By getting close to 40, and I'm going to use 40, it's easy to round up to 40, by getting to 40 nanograms per milliliter, this study showed a 77% reduction in the incidence of all cancers. The take-home message from that to me is that there's no way that I'm ever going to let my serum level be below 40. A couple of other studies that have been done that can show specific serum levels that I think are very interesting. One is vitamin D and tuberculosis. These people had 10,000 international units a day or a placebo group, and at the end of their study, everyone who had gotten the vitamin D had what they call sputum conversion. In other words, there was no evidence of tuberculosis in that group. But what was the serum level that they got to? Not just vitamin D, but what was the serum level? Well, based on what 10,000 IU would do for our population, where we had more than 700 people, their average serum level was probably about 60 nanograms per milliliter. That's bigger than 40. And it's certainly bigger than 20 or 30. But that's what it took, and it worked. And again, you can note in this particular study, as in many others, that level of intake and that serum level was safe. The other one that I want to show you is about pregnancy outcomes. This was a very significant study where there was a 50% reduction in neurocognitive deficits in that group, that fourth group down there that was in the 29 to 62 nanograms per milliliter. So at least they were in the 40 nanograms per milliliter range. So the actual serum level is very important to know, because that is what you are aiming to achieve. Dr. Heaney, we're back to you with Native Americans and what that tells us.
Well, Native Africans, anyway.
Oh, I'm sorry.
The point that we'd like to make here is, what would we have by way of vitamin D status had we been living where the human race evolved in equatorial East Africa? And the answer to that question is provided by blood tests that have been done and published on populations living in that region and following ancestral lifestyles. Now, there are two major groups there. There are the cattle herders, the pastoralists, called the Masai, and you can get some idea of how much skin they might typically expose. They're getting sunshine most of the days of the year. And the other group are hunter-gatherers. They don't have cattle, they don't have anything, they just gather what they can and hunt as they can. Well, what kind of vitamin D levels do they have? Here, the Masai are shown on the left with a value of nearly 50 nanograms per milliliter, and the Hadzabe, the hunter-gatherers, with a value of about 43 nanograms per milliliter. And there's the average of those two groups. There's no statistically significant difference between them. And I think we have to take that as the best estimate we have of what the ancestral intake would have been when our physiologies were evolving. This is what our bodies were seeing and were expecting and were reacting to, and we based our physiology on what the environment provided. Now, by contrast, we see what the Institute of Medicine has recommended for us a year or so ago, only 20 nanograms per milliliter. That's a good bit short of that figure that we've been talking about, 40 nanograms, and surely short of the ancestral value. The Endocrine Society, as some of you may know, has come up with a somewhat less conservative recommendation, saying, well, you shouldn't be below 30. And we certainly agree with that. Being below 30 puts you at risk for all kinds of problems. But both of those numbers are substantially below the ancestral level. And so we take some assurance from the fact that values above 40 appear to have been what the human race experienced when it was developing. So to wrap up and to leave time for questions, we want to remind you that vitamin D inadequacy is common, and that serum 25-hydroxyvitamin D is the physiological indicator of what our vitamin D nutritional status actually is. The Institute of Medicine had pegged 20 nanograms as the lower end of what they considered normal. The Endocrine Society used 30 nanograms, and most clinical scientists working with vitamin D every day would recommend 40 nanograms. So this is simply to put you in contact with what's out there in the environment here. Next, a point that we've made is prediction of 25-hydroxy response to any given dose is subject to very large variability. And as Carol has said, different health effects probably require different levels. And for example, she stressed that cancer probably requires 40 nanograms per milliliter, and tuberculosis maybe 60. The cognitive benefit in children born of mothers with low vitamin D status is achieved somewhere between 30 and 60 nanograms per milliliter. We don't have enough data to nail it down, but we surely wouldn't want to be below 30.
Dr. Heaney?
Yes, Carol.
On that slide, the prior slide, if it's possible to go back to that, I want to re-emphasize, if I may, the fact that if I'm out here as an individual or as a physician advising my clients, my customers, what level should I be at? To me, I would advise them to be at the very, very highest level that appears to be safe and that covers any disease conditions that are known, like that tuberculosis one or cancer. My gosh, that cancer one was a randomized trial. In my mind, there's no excuse for anything less than 40 because the data's there and we all know it's safe. Thank you.
There's no question about the fact that 40 is safe. I try to keep my vitamin D level above 40, and I'm sure Carol does as well. So there's no real argument there. We're simply showing you I think the important point is that you can probably fix some disorders at lower levels, but as Carol stresses, why go for a lower level? You fix all of them if you peg a higher level, and 40 to 60 probably captures most of them. Well, to wrap up, as I've shown you, East Africans who are living close to ancestral lifestyles have values about 48 nanograms per milliliter. These are fully physiological, and as I'm sure many of those in the audience know, those levels are commonly exceeded by outdoor summer workers in our own country. If you expose a lot of skin, by end of summer, you're going to have values above that. Nobody's ever gotten sick from that. There are no complications from that. So I'm comfortable with stressing how natural such high levels may be. But in any case, and back to why test, whatever criterion of adequacy you may choose, whether you want to go with a very conservative Institute of Medicine value, which we don't recommend, or whether you want to go with the ancestral value or somewhere in between, the adequacy of what you're taking can only be ascertained by measurement of what the 25-hydroxy-D level is. We can't predict that in advance because different people respond to the same dose in different ways. So, to conclude, drive home this point. Monitoring of therapy requires measurement. We can't guess it. And to anticipate a possible question, serum 125 dihydroxyvitamin D does not reflect vitamin D nutrient status and has very little diagnostic value. We use it in endocrinology to try to understand and work out obscure cases that don't seem to fit the patterns. But for the average person, there's no reason ever to get a measurement of 125 dihydroxyvitamin D, even though that is technically the active form of the vitamin. It's 25-hydroxy-D where the action is. That's what we need to measure. And with that, we thank you, and we'll be happy to take your questions.
Dr. Heaney, we have quite a number of questions. Whoops. So one of the very first ones here, or the category, was responses to supplementation, and they all, to some extent, reflect what you have been saying. The first one, someone 65 years of age, their D level went from 52 nanograms per ml to 61 when they increased their intake from 1,000 to 2,000 IU a day. Should they keep their level below 60?
Well, I don't think there's any one answer to that question. Probably 60 will cover most of the protective benefits that you can get from vitamin D, but it's safe to go up. There's never been any report of toxicity below 200 nanograms per milliliter. I don't recommend going that high, but it's good to know that 60 and somewhat higher will be safe.
All right. The second question, I tested at 141 nanograms per ml in 2011 by taking 10,000 IU a day. And then I changed to 6,000 IU a day and tested at 93. Is this a good level? I'm 68 years of age and 115 pounds.
Yes, that's a good level. You could afford to go lower still, because I'm not sure you'll be getting additional benefit. But what you do demonstrate here is that you're getting a bigger rise than somebody else might because you're a small person. And so the same amount put in your body produces a higher concentration. It's just that simple. So it's an interesting illustration. But 93 is safe, not to worry.
And question number 3, why do some of my patients have difficulty increasing their D level of above about 60 nanograms per mil no matter what dose? Are there other health issues or conditions to be aware of?
Well, Carol anticipated the answer to this question when she showed that even at high doses, there are going to be some people who are under 40 nanograms per milliliter, and you just have to keep pushing if you want to get above that. We think that the reason for that is that there's difficulty converting D to 25-hydroxy-D, and different people have different capacities. That's all. Some are able to do it better and faster than others. The important thing is the blood level, however, and it's good to be above 40. I'm not sure there's much benefit to going above 60, at least not for ordinary health. Excuse me. But this is, again, an illustration of the fact that not everybody's the same and they all respond differently. There could be health issues that, I mean, if you're taking anticonvulsant medications, for example, that leads your body to get rid of a lot of things very quickly. That includes vitamin D, which you don't need to get rid of, but it does it anyway. So people taking anticonvulsants commonly have a much higher requirement than people who don't. But by and large, we're talking here about healthy people, not people with other health issues.
All right. Additional questions on that topic? After taking 5,000 IU a day, my serum was 49 nanograms per milliliter, then to 10,000 IU a day. The level stayed at 49 nanograms per milliliter. Why?
Well,
how?
Yeah, I think we've just discussed that. Your body's using it up as fast as you can take it in, so it just won't budge. But 49 is a very good level, so I mean, I wouldn't be concerned about that. But another factor that I think we don't adequately deal with is that the Food and Drug Administration requires supplement manufacturers to meet certain standards. If they say that there's 1,000 international units in a capsule, they expect it to be 1,000 international units. But they have a surprising amount of leeway. It can be as low as 800, and it can be as high as 1,600, and both of those numbers will meet the FDA requirements. So you may get one batch that had, say, 1,600 where the label said 1,000, and you may get your next batch that's only got 800 instead of the labeled 1,000. And if that's what happened when you skip from one to the other, you're actually taking twice as many capsules but getting the same amount of vitamin D, just because of the variability in what's in each dose unit, the capsule, tablet, whatever. So that's something we just have to live with. That's the leeway the Food and Drug Administration allows supplement manufacturers. It makes it very difficult for us as researchers, where precise dose is absolutely essential, or we can't answer these kinds of quantitative questions. And for that reason, when we do a study using vitamin D, we always send samples to a laboratory to get the actual vitamin D content measured. It's almost never what's on the label. It's close. I mean, it's within 80 to 160% of what's on the label. It's not 1,000% or 10% of what's on the label. It's within an appropriate range, but it's different.
All right, and number 2 on that slide, my physical showed 29 nanograms per milliliter with 1,500 IU a day. My physician put me on 3,000 IU a day. Will this increase my level? I live in Maine.
Well, your physician expects it to, and I would expect it to. It probably won't double because you're getting more than 1,500 because you've got other sources that we don't know about. So if you double from 1,500 to 3,000, you'll probably get up close to 40. But we won't know until you measure, will we?
Testing. If you have tested and gotten to the 40 to 60 nanogram per milliliter consistently, do you still need to check annually?
Well, there are two reasons for checking annually. One is just to provide you with some reassurance. The cost of the test is modest, and if you have to pay for it yourself, it won't break the bank. But if, in addition, you have a change in your health condition and you're taking other medications, then that could change how your body handles vitamin D. So yes, under those circumstances, I would certainly test annually. But technically, you don't need to if there's been no change in your health status, except to give yourself the reassurance that you're on the right track.
In terms of that one comment from some people in our study, some people in the study, they have variations in their vitamin D level, which are big enough swings that they care. Like, for example, somebody going from 45 on one test down to 30 or 35 the next one, and they're still taking the same amount, and there's no totally defined reason why. So it is reasonable to check.
Yes, let me just add, Carol, that as you say, they're taking the same amount. By that you mean they're taking a tablet that's labeled on the outside of the bottle as the same amount.
Exactly.
But from one year to the next, you're not out of the same bottle. You've got different lots, different samples, different purchases, and they may well be different one from the other. Right. So, I've already stressed that, and right. I suspect most people are surprised at that, but that's just the facts.
Okay. If allowed only one test per patient per year, when would you do it?
Well, if you want to know when you're at a neutral point, it would be late spring. That averages out the differences between summer and winter, if in fact you're going outdoors enough to make a difference. But although sun exposure was the principal source that we got in times past, most of us work indoors. Most of us don't see the sun except through the windows, and so the time of year doesn't really make as much difference as it did once. When we look at the variability between people in blood vitamin D level, time of year accounts for only 2% of that variability. 98% variability is due to something else, not time of year. So really, I don't think it makes a lot of difference, but if you want to reach the neutral point where you're halfway between winter and summer, it'd be late spring. Bear in mind that the blood vitamin D level lags the seasons by about 6 weeks, so you don't really reach your summer peak until mid to late August, and you reach your winter nadir bottom sometime in early February for the most part. So somewhere between February and August, you can find a midpoint, and that's safe.
How long after starting a supplement should I wait to be tested?
That's a very good question. The best answer I can give is that you'll see a rise immediately, but you won't know how far it's taking you until you wait for 3 to 4 months. So a 3-month minimum would be what I would say. 4 months is probably better. And if you are, to skip ahead to this next question, if you're in steady state and we know that you're at the level you want, then annually is plenty often.
Fantastic. We are going to do a closing announcement for our next week's seminar, and then Dr. Heaney, we will come back and answer a few more questions. But for those people that truly have to leave right at 10:30, I want to make them aware that next week, actually, we're going to have one of a 2-part series about prostate cancer. Next week is with Dr. Bruce Hollis, and the following week will be with Dr. Reinhold Vieth. Both of them have recently completed randomized trials with vitamin D and prostate cancer, and they're very different studies. Dr. Hollis' study was actually giving 4,000 IU a day for a full year to men who had prostate cancer, and to see what the effects were. And Dr. Vieth did a randomized trial of giving men, and one of the groups had 40,000 IU a day for 6 weeks prior to a scheduled radical prostatectomy. both of them had positive effects. So I encourage you to stay tuned, share the word about those upcoming webinars for the next 2 weeks. Thank you very much for coming today, and spread the word and get your vitamin D tested. And Dr. Heaney, we will go back to answering questions for those that have chosen to stay on.
Okay, I'm here.
All right. The reliability of tests. How accurate is the typical vitamin D 25-hydroxy-D test?
Well, there isn't a typical one, unfortunately, but the accuracy is going to be plus or minus, say, 7%. That'll be a smaller number for a low value and a larger number for a high value. It's a percent variation, but somewhere in the range of 5 to 7% is probably as close as you can do. But it depends on how good the lab is. They're difficult tests.
Okay. Can one get reliable vitamin D testing from local labs? I think that's a very general type question, but maybe you could still comment on it, please.
Well, it depends on the local lab, doesn't it, Carol?
Right, it does.
Most of them, in my experience, most of them send them out to some of the big central labs. And so they should get fairly reliable results. But
one of the things that people might look at if you're really into knowing how qualified the lab is, there are 2 different standards groups now that a number of labs are participating in to calibrate their own standards and make sure that they are up to snuff. One is NIST, the National Institute of Standards Technology, sends out known samples to them anyway, and has the lab run their test to see how good a match there is. And then the other is DEQAS, DEQAS. So if you're interested in the quality of your lab, you might want to query what standards do you use to measure your samples. Okay. On supplementing, some questions. How consistent do I need to be in dosing? Daily, 2 times a week, etc.?
For some medications, frequency of dosing is critically important. And for water-soluble vitamins, that's probably true as well. But for a vitamin such as vitamin D, the body is very forgiving, and you can take it daily, twice a week, once a week, maybe even once every 2 weeks, and get essentially the same results. The real answer to the question, therefore, is which regimen will work best for you? Some people prefer to take their vitamin D on a Sunday morning. It just becomes a part of the weekly routine. They may be out on the road or traveling or following different schedules during the week, and then they forget or they don't have it with them or something of that sort. So personalize this. Choose something that will help you adhere, knowing that you don't have to do it every day. That, say, weekly is just as good as daily. But of course, I mean, a weekly dose should be 7 times as large as the daily dose, and a twice weekly dose should be 14 times roughly. So please pay attention to that.
I want to add a unique kind of exception in that category to lactating women.
Good point, Carol.
The research from Drs. Hollis and Wagner indicated that the vitamin D does not transfer adequately, or actually you need to take it daily. So if you're a lactating mom, take your vitamin D every single day. It's very important.
Yes, let me follow up on that, Carol.
Please.
The mother can have a perfectly good vitamin D status as measured by 25-hydroxy-D level, but the 25-hydroxy-D doesn't get into her milk. And so if she wants the baby to get the vitamin D she has, it's got to be in the form of native vitamin D. So she does need to take it every day, because if you stop taking your vitamin D, your blood level of vitamin D itself drops fairly rapidly, even though your 25-hydroxy-D, which is the measure of how, of the vitamin D status for you as an individual, that may remain okay, but you're not able to put vitamin D in your milk at that point. So with that one exception that Carol points out, for lactating women, you do want to take it daily.
And to some extent, you sort of, well, you really haven't. Let's do number 2. How long does vitamin D last in the body?
Well, there's no one answer to that question, because if I'm giving vitamin D to you and you're deficient, then it doesn't last at all. It gets used as fast as I can give it to you. If I'm giving you more than you need, then it gets stored in your fat, which is useful, because then that can tide you over days when you don't get any, or the seasons change, or you've got an illness in which you need more vitamin D and you're not taking it because you can't take anything. But so there isn't one answer to that question. If you ask how long does vitamin D last in the bloodstream, now this is native vitamin D, well, it has a half-time of about 2 to 3 days. Whereas if you ask me how long does 25-hydroxy D stay in the bloodstream, but that has a half-time measured in the range of 3 to 5 weeks in the blood. So there isn't a single answer to that question. It's just that if you get enough, then you'll have enough.
Good answer. Number 3, what's the optimal concentration of 25-hydroxy vitamin D and intake of calcium for the prevention of hip fractures?
Well, as far as vitamin D is concerned, the best results have been shown at values above 100 nanomoles or 40 nanograms, the number we've been talking about all day today. 40 nanograms and up have produced the best results in terms of prevention of hip fractures. Calcium probably needs to be in the range of 1,200 to 1,500 milligrams per day. But calcium doesn't do much by itself. It needs the vitamin D. And when it comes to bone, vitamin D needs the calcium as well. So these are really partners that have to go together. But that's true of all nutrients. We need to think about nutrients as players in a symphony orchestra. We can't do Beethoven's Fifth on the trumpets alone or the harp. We need all the instruments of the orchestra. And so if we're concerned to reduce our risk of hip fractures, it's not just vitamin D, it's not just calcium, it's not even just vitamin D and calcium. It's vitamin D, calcium, protein, and a dozen other nutrients as well. Protein's a forgotten member of that trio, and those are probably the 3 most important for hip fracture. But the important thing is we need total nutrition, not isolated nutrients.
All right. And UVB are supplements. Is vitamin D taken orally the same as getting it from the sun?
We think so. There is one study that suggests otherwise, but the routes and types of vitamin D were so different by the 2 routes that I don't think the study tells us very much. But if you hear somebody saying that, say there was a study, well, there was one, but I don't think it really enlightened the topic. Most of the evidence that we have suggests that the 2 routes are about the same.
How can we guide the amount of sun or UVB exposure for optimum results?
This is a very controversial type of question because whereas sun is the natural source of vitamin D for us, from the UVB rays that are contained in normal sunlight, at least in the summer, sun can damage the skin as well. It certainly produces drying and wrinkling if it does nothing else. And certain forms of cancer, such as squamous cell carcinoma and basal cell carcinoma, have been known for a long time to be related to sun exposure. And we don't want to get any of those things. Modest sun exposure, and it makes us feel good. If we use sunscreen, we can protect the skin, but if we use it right, we won't make any vitamin D either. So, I wouldn't use sun and sunscreen in the hope of getting vitamin D, because that won't happen. For the most part, I think most of us are going to have to rely on getting vitamin D from supplements or from fortified foods. Fortification is probably the most efficient way at a population level because everybody gets it without having to think about it. But until then, we're going to depend upon individual initiative and the choice to take and keep taking supplements.
And Our last question, if one person got their D by sun and the other by supplements, would there be any reason to suspect one would have better health than the other?
Well, that's another way of phrasing question one, and my best answer is no. There's no reason to suspect that one would be any better off than the other.
And I have to add a small aside on that one. The sun does other things than vitamin D. So
Yes.
if one limits it to vitamin D, I think that vitamin D health would probably be the same. But there may be other things yet that we just don't know enough about.
And in that same sense, as we already stressed, those getting their vitamin D by sun may well have more wrinkling.
That's okay.
So that works both ways. That works. But this is a question about vitamin D, and
Right.
I mean, so far as we can tell, the vitamin D status is the same.
Right. Thank you again, Dr. Heaney, for your participation and guidance today. We very much enjoyed it, as we always do, and I enjoyed the opportunity to present a little bit with you as well. And again, to all of you, for next week and the next 2 weeks, we will have sessions on vitamin D and prostate cancer with Drs. Hollis and Dr. Veith. Until then, please take a look at our website. You can see other videos that we have posted out there on grassrootshealth.net videos. And we are absolutely delighted that you have chosen to participate. Thanks again.